Hello. Hello. Friends, on behalf of the Indian Society of Hypertension, I have great pleasure in inviting all of you here for this scientific session this evening. This is considered as a satellite meeting before the Congress. The Congress is going to be held only at the Chennai Trade Center, this being the venue only for the scientific session this evening. In fact, we are very much thrilled to see many of the international faculties are here, and we are expecting much more number tomorrow. I'm excited to tell you that about 1,700 is the registered delegates. They will be attending the Congress from tomorrow. I think we need not waste time because people are slowly coming in. The first session that we have selected is about aldosteronism. In fact, a lot of interest has been shown in this particular field, not only in various journals, including the guidelines that have changed the approach for the management of aldosteronism. We have eminent speakers here. Dr. Michael Strohwasser, he is the editor for the Journal of Human Hypertension, and Dr. Leilani Assis from the Philippine Society of Hypertension president, and she had done a lot of work in the field of hyperaldosteronism. In fact, we have requested Dr. Michael Weber, who is an authority in the field of nephrology and had conducted a lot of trials in the past, including accomplished trial. And I'm really happy to see him here. And I don't want you to climb here. Probably you can take the mic and introduce the first speaker to come to the dais. Once the first speaker finishes his lecture, we will not entertain any question. We will move on to the second talk, which is going to be by Dr. Leilani Assis, who will be sufficiently introduced by Dr. S. Murthy. Dr. S. Murthy does not require introduction to this audience because he is a known endocrinologist, very well known endocrinologist of this country, and he was the past president of the Endocrine Society of India. In addition, after the two talks are over, Michael Berber and Murthy will be probably requesting Dr. Krishna Sheshadri, who is an endocrinologist of this country, and Dr. Shashank Joshi, again, a leading endocrinologist of this country. Both of them will be introduced by them, and the question and answers will be probably from the audience and from the people who are trying to log in from various parts of this country. Nearly about 40 destinations have been covered. All of them will be inclined to listen to you, inclined to raise some questions regarding the doubts. You are the masters to deal with that. Thank you very much.
Well, thank you very much, Dr. Narasimhan. And for me, it's a particular pleasure to be part of this program. I think we'd all agree that managing patients with hyperaldosteronism is not something that is done well in the community. So many patients who have this condition are simply undetected and untreated. And we're hoping that what we learn tonight will play a big part in moving the field along. So it's my pleasure to start by introducing a very distinguished expert in the field, Professor Michael Strohwasser, who is director of the University of Queensland School of Medicine, of course, in Queensland, Australia. He's the head of the hypertension unit at the Princess Alexandra Hospital, and Michael has really made enormous contributions to the field of aldosterone. And so please, I'm going to invite you to come and talk to us about the prevalence, the clinical importance, the diagnosis and management of primary aldosteronism, including new developments. Thank you very much, Michael, for joining us.
Well, thank you very much, Michael. And it's a great privilege to be in this country. It's the first time I've ever been to India, and it certainly won't be the last. We had a wonderful time today. My wife and I are seeing some of the sights of Chennai. and it's a great honour to be addressing this distinguished audience today. So primary aldosteronism is a condition in which there is excessive and autonomous production of aldosterone by the adrenal glands. This leads to salt retention, and this leads to hypertension. And the salt retention has a negative feedback effect on the kidney to suppress the production of renin. At the same time, aldosterone causes excessive potassium excretion, and if this goes on for long enough and is severe enough, a patient may end up with hypokalemia. Conn's first patient with primary aldosteronism was described in 1954, a 34-year-old female with severe hypertension and severe hypokalemia, which were cured by the removal of this 4-centimetre aldosterone-producing adenoma situated in the right adrenal gland. For many years, it became dogma that primary aldosteronism was a rare condition accounting for less than 1% of hypertension, and that the search for it need not be undertaken unless patients had hypokalemia. I was very fortunate enough to meet my mentor in the early 1990s, at about the same time that he decided to challenge this dogma by screening for primary aldosteronism using the aldosterone to renin ratio, not only in patients with hypokalemia, shown here in red, but also in patients with normokalemia. And by making this simple change to his screening practice, as you can see, the detection rate of primary aldosteronism by our unit went up logarithmically, in fact about tenfold, from 5 to 10 cases a year to 50 to 90 cases per year, with the majority of patients being normokalemic, shown in green, and therefore lacking the characteristic hypokalemia that was thought to be so important for the condition. We've been able to amass over 2,500 patients in our 2 hospitals alone and remove over 500 aldosterone-producing tumours. We found prevalence rates for primary aldosteronism of about 9.5% among normokalemic hypertensive referrals and about 12% among hypertension drug trial volunteers. Not long after our report, many other units similarly began reporting very high prevalence rates for primary aldosteronism. This is just a selection, with rates of about 5 to 15% of their hypertensives having PA, and again, most of them being normokalemic. So why is primary aldosteronism so important not to miss? Well, as you've heard, it's the commonest secondary endocrine cause of hypertension, accounting for about 5 to 10% of cases. And we know that specific treatment, including unilateral adrenalectomy for the unilateral forms of PA, and agents that antagonize aldosterone action, like spironolactone for bilateral PA, are very effective at lowering blood pressure. So here is just one of our series that we published of 22 patients who underwent unilateral adrenalectomy after being found to have a unilateral form of PA. And within 3 to 6 months of the operation, 86% of patients were cured of hypertension and the remainder improved. The proportion with controlled hypertension rose from 14% to 100%, and in those who did have hypokalemia, it was corrected in all of them. And you can see on that table the drops in blood pressure, the drops in aldo, the rise in renin, the drop in the aldo-renin ratio, the rise in potassium, and the fall in the average number of medications needed to control hypertension from 2.7 down to 0.1. In bilateral primary aldosteronism, spironolactone and eplerenone can be highly effective at controlling the blood pressure and raising potassium, as you see in this Greek study. Thirdly, aldosterone excess has adverse cardiovascular effects that go above and beyond hypertension. So patients with primary aldo have higher rates of heart attack, stroke, and arrhythmias than those with essential hypertension. This is one of the seminal papers that demonstrated this from Italy, where you can see that compared to the essential hypertensives matched for blood pressure level, those with primary aldosteronism had a 2.8-fold higher risk of heart attack, a 4.4-fold higher risk of stroke, and an almost 5-fold risk of arrhythmias, usually atrial fibrillation. And yet specific treatment directed against aldosterone excess reverses this excess in cardiovascular morbidity and greatly improves quality of life in many of these patients. So in this same Italian study, once they either applied unilateral adrenalectomy or commenced spironolactone, you'll see that the rates of cardiovascular events in the essential hypertensives and primary aldo patients became virtually identical. So this led the authors to conclude that primary aldo is associated with a cardiovascular complication rate out of proportion to the blood pressure levels, and it benefits substantially from surgical and medical treatment in the long term. And that's really closed the loop here to say why it's so important to diagnose this condition so that patients receive optimal treatment and optimal benefits in terms of their long-term outcomes. So the diagnostic workup is what I'm going to spend pretty well the rest of the talk on. This is divided up into 3 phases. Screening by measuring the aldosterone to renin ratio, confirming the diagnosis by performing some form of suppression test. In Brisbane, we use a test that we designed a few years ago, the seeded saline suppression test. In the Mayo Clinic, they use the oral salt loading test. And then finally, distinguishing unilateral forms, which are surgically correctable, from bilateral forms, which are usually treated medically, by a combination of adrenal imaging with CT or MRI and adrenal venous sampling. So let's start with screening. Probably the biggest difficulty with screening is the effect of medications on the ratio. The screening test itself is pretty simple. It's just a single blood test done in the morning, and it's relatively cheap, so it costs about the same as a lipid profile. But you get false positives when patients are taking drugs that suppress renin, such as beta blockers, alpha-methyl-dopa, clonidine. And you get false negatives when patients are taking drugs that either stimulate renin or lower aldo, or both. So diuretics, the dihydropyridine form of calcium blockers like amlodipine, ACE inhibitors, and angiotensin receptor blockers. So in Brisbane, our approach is to avoid those drugs while we're doing the workup, and instead use one of these or a combination of these aldo-renin ratio inert antihypertensive medications such as verapamil, slow-release, hydralazine, prazosin, or moxonidine. So our approach in Brisbane is that we stop the diuretics, including spironolactone, for at least 4 weeks, and we stop all the other interfering drugs for at least 2 weeks. And during that time, we substitute them as required with other medications that don't affect the ratio, verapamil, hydralazine, prazosin, moxonidine. When we're ready to take the blood, we collect it in the morning when aldo levels are at their highest, and after at least 2 hours out of bed, usually in the sitting position because upright posture stimulates the aldo level. Now, this has been one of the main drawbacks, if you like, one of the main deterrents for people for looking for primary aldosteronism, is that how complicated is this to have to stop drugs, and in doing so, potentially placing patients at risk of outcomes from uncontrolled hypertension. As a result, the screening rates for primary aldo around the world are a little better than dismal. So even in Australia, less than 1% of hypertensive patients are screened for primary aldosteronism. I'll let you know that the European Society of Cardiology, European Endocrinology, have both recommended in their latest guidelines that every patient with hypertension be screened with an aldo-renin ratio. So how is that going to happen in real life practice? It's going to be very difficult to achieve. As a result, bodies such as the British and Irish Hypertension Society have tried to publish more practical guidelines on how this can be done. Bill Young at the Mayo has done exactly the same thing. He's tried to take us through an approach that may be a little bit more achievable than what has been published in the US Endocrine Society guidelines up until this point. So what they recommend, yes, you use the aldo to renin ratio. Yes, you consider stopping the beta blockers and the centrally acting sympatholytic drugs to try and get rid of your false positives. But they say that the withdrawal of all antihypertensive medications for screening is not necessarily or routinely recommended. And instead, they say that when you're assessing the ratio, consider confounding factors such as these drugs and what they may be doing to the ratio, or indeed what they may be doing to the components of the ratio, the renin and the aldosterone. So let's take you back to the slide I showed you before, and we'll have a look and see how you might do this. And what I'll show you now is the pattern that you might expect in aldorenin levels and ratios with each of these groups of drugs. So for beta blockers, yes, they will have a low renin, but the giveaway is that the aldosterone tends to be low as well, or in the lower part of the normal range. So for example, if you had an aldo of 200 picomoles per litre and a renin of less than 1, that will give you a raised ratio. But the aldosterone level of only 200 picomoles per litre really makes it very suspect that the patient has primary aldosteronism. With diuretics and the dihydropyridine calcium blockers like nifedipine and amlodipine, you get a high renin and you see a normal to high aldo. So if you see that pattern and you're on one of those drugs, you may think, I might have a false negative because of that drug. ACE inhibitors and aldosterone angiotensin receptor blockers give you quite high renin, and they tend to give you very low aldo, because if your angiotensin receptors on the adrenal cortical cells aren't being stimulated, then you're not making aldo. So people on these drugs often have the lowest ratios of all. So if you come across patients who have what you think is an equivocal result, or you are quite suspicious that they've got primary aldo and yet they've got a negative ratio, this is when the British and Irish Hypertension Society say, consider repeating the ratio off those drugs in those situations, but not necessarily in every patient. So I'll move on now to confirming the diagnosis. Now, some years ago, we developed this new test called the seeded saline suppression test that has now become the standard approach to diagnosing primary aldosteronism in Australia and in many other places of the world. So here we have a patient who it's done in the morning. They assume the seated posture for at least 30 minutes. You then collect blood for aldo, renin, potassium and cortisol at baseline. And then after 4 hours infusion of normal saline, you give 2 litres over 4 hours, which is 500 mils an hour. And we start that at about 8 o'clock in the morning, so it will finish at midday. Very important to do this in the morning, because aldosterone has a natural circadian rhythm, such that towards late morning, midday, aldosterone starts to shut off. So if you haven't started your saline suppression test by about 8 or 9 o'clock, you may get a false negative because of the diurnal rhythm of aldosterone. Under these circumstances, the failure of aldosterone to suppress to less than 217 picomoles per litre measured by immunoassay, or less than 162 picomoles per litre measured by mass spec, if you're lucky enough to have that facility, confirms primary aldosteronism, provided that the infusion has suppressed renin, because if it hasn't suppressed renin, you can't hope to suppress aldo, even in a person who doesn't have primary aldosteronism. And the second property that you need of this test is that cortisol at the end of the infusion should be no higher than at baseline. And that therefore rules out a stress-induced rise in ACTH that could have stimulated aldo and prevent it from suppressing, thereby causing a false positive. We found in our publications that this test is far superior to the older, more traditional recumbent saline suppression tests where people would do the test lying down. And that's because aldo is responsive to upright posture. So you're starting with an aldo level in the seated position that's considerably higher than in the lying down position. So it's got longer to fall before it goes past normal suppression point. It appears to be more sensitive than the recumbent saline for picking up PA, even with the surgically curable forms. And it has quite low rates of false positives, 6%, false negatives, 13%, but these are almost always bilateral PA, which doesn't really matter if you miss it, because you can still put them on spironolactone if you want to. Like recumbent saline suppression testing, you can do this as an outpatient procedure, and it's better tolerated than recumbent because people can get up and move around, go to the toilet if what they need to, and they usually do because they're getting 2 litres of salty water over a 4-hour period. Once you've convinced yourself that you have true primary aldosteronism by your suppression test, the final step is to determine, is it unilateral or bilateral? Aldo-producing adenoma makes up about a quarter of patients with primary aldo. The bilateral forms make up almost all the rest, and then rarely do we have aldo-producing carcinoma and familial forms, which I won't talk about any further. CT scanning and other forms of imaging are quite good at picking up aldo-producing carcinoma because they're very large. They're also very rare, so this really doesn't account for many of our patients. What's much more difficult for imaging is to pick up aldo-producing adenomas. So this was one series from the late 90s where we had 111 aldo-producing adenomas removed, of which only 50% were picked up by CT. And this depends, of course, on the size of the tumour. So for those tumours that were less than 1 centimetre in diameter, CT only picked up 1/4 of them. And furthermore, even if you see a lump on CT, you don't know for sure that it's the source of the aldosterone excess, because APAs look identical to adrenal incidentalomas on CT, indeed as they do pathologically. So here are 2 CTs from 2 different people. The top one is a 45-year-old man. The bottom one is a 53-year-old woman, both with hypertension. They look almost identical. The arrow points to a 1 centimetre nodule in each of these 2 individuals' right adrenal gland. The male at the top had adrenal vein sampling, which lateralized to the right adrenal, and removing that tumour led to cure of the hypertension. The female in the bottom, however, had bilateral aldo production on adrenal vein sampling, and therefore removing the right adrenal would probably have had no beneficial impact on her hypertension. And here's another one where you could clearly see above the left kidney a lump in the left adrenal gland. Adrenal vein sampling actually lateralized to the right, and removing the right adrenal, which had a much smaller nodule that was mixed on CT, led to a marked improvement in hypertension control. So for all these reasons, we believe that adrenal vein sampling is the most reliable way of separating unilateral primary aldosteronism, mostly aldo-producing adenoma, from bilateral primary aldo, and for lateralizing the tumours preoperatively. And therefore in Brisbane, we do this in all of our patients with primary aldosteronism. Now, the problem with AV sampling is that it's technically very challenging, and especially getting into the right adrenal vein. So you can see from this picture that the right adrenal vein, the arrow pointing to it there, is really quite small and empties directly into the inferior vena cava. So you have to try and get your catheter to find this little hole in a huge pipe, which can be very difficult. The left, on the other hand, you can see the left adrenal vein empties into the renal vein. So you've got a direction finder to get into the left adrenal vein. So it's usually the right that is missed. And in centres that don't do this very often, you have success rates of getting into the right adrenal vein as little as 30 to 40%. So how do we get around this? Well, the first way around it is experience. And to do this, you need a decent throughput. So you need a person to do at least 15 of these procedures a year. And the best way to do that in each hospital that offers this is to limit the number of doctors who are doing adrenal vein sampling to just maybe 1 or 2, and not just let every radiologist do it. So at Greenslopes Private Hospital, you can see here how the success rate with a new radiology group went up very quickly from less than 50% to 90% over a few years' time. Another way to improve this is to use ACTH stimulation, which does seem to improve the so-called success rate of cannulation. And a third method is to get a contrast CT done in the venous phase prior to doing adrenal vein sampling. So you can see on that slice there, you can see where the adrenal vein empties into the IVC. And by knowing how high that slice is on the scalp film, that gives the radiologist a rough guide as to how far north their catheter needs to go to get into the vein. But probably the most phenomenal improvement has been with the introduction of point-of-care rapid cortisol assays. So these assays now can be done on a strip that looks a bit like a rat test for COVID. And it measures in the adrenal venous serum cortisol. It's a competitive assay, which means that the higher the cortisol level, the fainter the band. The top band on each of these slides is a control band. It just tells you that the assay is working. The bottom band in pink is the test band. So you can see the peripheral veins, which is the first and second strip, has a nice bright band, whereas the adrenal veins, which are the second, third, fourth, fifth, and sixth strips, the band has disappeared. So we know within a minute of collecting the blood whether the radiologist has got into the adrenal vein. Radiologists love this because it means that they get instant feedback, so they become educated very quickly as to what looks like an adrenal vein on the fluoroscopy images. Secondly, it means they can finish early. In the old days, when radiologists were uncertain that they'd got in, they would do 6, 7, or 8 attempts before they felt they'd done enough. Now they can finish after the first couple, go have a cup of coffee. And of course, the most important reason this is good is that it has improved success rates. At our institution now, success of getting into the right adrenal vein is well above 95%. And there's been quite a few papers showing that even in experienced centres, the use of these strips has further improved success rates. Now, of course, adrenal vein sampling is technically challenging, it's somewhat invasive, and it's not available in many centres. And this is going to be the huge bottleneck that's going to happen when we have hundreds and hundreds of patients being screened for primary aldosteronism, being found to have PA, and now we've got to see if we can get them through adrenal vein sampling. So there are some developments which may help to solve this conundrum, and one of them is the use of new forms of nuclear imaging. So Maurice Brown's group developed this scan called the metomidate PET-CT. It uses metomidate, which is a molecule, the tracer, that actually blocks a number of steroid synthetic enzymes, so it targets the adrenal cortex, and it uses 11C as the isotope. Maurice Brown's group has looked at this and compared it with adrenal vein sampling and found that the scanning was at least as accurate in the prediction of outcomes from adrenalectomy versus adrenal vein sampling. But C11 metomidate has a couple of problems. Firstly, it's got a very short half-life of only 20 minutes, which means that you have to have a cyclotron in your own city to be able to get the isotope to the radiology practice in time. And secondly, metomidate is not specific for aldosterone synthase. It blocks also other synthetic steroid enzymes, including 11-beta hydroxylase, which of course is the final step in the production of cortisol. So you're going to be lighting up not just aldo-producing cells, but cortisol-producing cells. And in order to stop that happening, they have to be pre-treated with dexamethasone to shut off ACTH and therefore shut off cortisol production through 11-beta hydroxylase. But there are improvements already happening. And this to me looks to be the most promising, which is F18 AldoView. So this is a tracer that specifically binds to aldosterone synthase. So it won't light up cortisol producing cells. And furthermore, it's got a much longer half-life of 110 minutes, which means that you can transport it to other cities from the place where it's manufactured. And finally, a quick run on the treatment of primary aldosteronism. And of course, if aldosterone overproduction lateralizes to one adrenal, then we can offer them laparoscopic adrenalectomy. So the laparoscopic approach you can see in the left compared to the old-fashioned open left adrenalectomy on the right. This means that people can be out of hospital within a day or two. Hypertension is cured in 50 to 60% and improved in all the remainder. And what we've seen with surgery is a marked improvement in quality of life. So patients feel much better in themselves. They're not having to get up all night to pass urine as they used to. So they have more energy, they are calmer and more relaxed. And this is something that you see to a lesser extent with spironolactone. So one of the things that we're going to see, I think, is that as more and more people are screened for this condition and suspected of having PA, then there will be places or situations where proceeding to adrenal vein sampling or even confirmatory suppression testing is not going to be feasible with the numbers that are going to be coming through the system. So I can envisage that we'll be seeing a lot more situations where in patients where you really don't think it's very likely that they're going to have unilateral primary aldo, maybe the CT was a negative, maybe they don't have very severe primary aldo because patients with APAs tend to have more severe disease, that we'll be seeing a lot more use of medical treatments of primary aldo. The first of which is to encourage dietary salt restriction because all the harmful effects of aldosterone require salt to be affected. So the hypertension, the cardiovascular, the renal disease, all of which are dependent on salt. And the less that the patient eats, the less of a dose of spironolactone or whatever drug you're going to need. We suggest to start with small doses, for example, spironolactone 12.5 to 25 milligrams daily, amiloride 2.5 to 5 milligrams daily, and increase them only gradually, because these drugs take a couple of weeks to kick in. So it doesn't make a lot of sense to increase the dose every day or two. You really need to put up the dose, wait for a couple of weeks, see what's happened, and then reassess at that time point to see if you need to increase. During that time, of course, as the drugs kick in, you can start backing off on the other agents, depending on the blood pressure response. You can use renin as a guide. So the restoration of renin from a suppressed level to within the normal range suggests that you are blocking aldosterone action effectively. So one way you might use this, you get your patient back, their blood pressure is still a bit high, their renin is still suppressed, so you might increase the spironolactone. On the other hand, if the renin is now mid-normal, you might need to increase some other agent, like an ACE inhibitor or whatever. Now, of course, the problem with using that approach is that whatever other drugs they're on could be affecting the renin. So I've found that patients who are being treated with spironolactone, if they're also on a beta blocker, 9 times out of 10, the renin will remain suppressed no matter what dose of spironolactone you push them up to. So you need to bear that in mind. If you're going to use this approach, ideally you keep using the non-interfering agents in combination with spironolactone rather than ones that affect renin. Avoid large doses, particularly spironolactone, which causes sex steroid-dependent side effects, gynecomastia in men, loss of libido, and in women, menstrual irregularities. In renal impairment and the elderly, avoid large doses because you might cause hyperkalemia. Use with caution in patients that are on other agents that put up potassium, like ACE inhibitors, ARBs, non-steroidals. Never combine them with potassium chloride unless you have very, very florid primary aldo and you need a little bit to keep the potassium normal. And if hyperkalemia is a problem, you can try adding a small dose of furosemide or thiazide if necessary, but be careful not to dry them out due to excessive volume depletion. You can consider combining spironolactone with one of the other available drugs, amiloride, eplerenone if you have it, in order to keep the doses low. So if you find a patient gets gynecomastia on 50 milligrams, then cut it back to 25 and add in, say, 5 or 10 milligrams of amiloride. Amiloride alone may be sufficient for some patients with mild primary aldo, and when it was freely available in Australia, which unfortunately it no longer is, we found a lot of our young male patients preferred amiloride to commencing spironolactone. In addition to blood pressure, you need to monitor their electrolytes and their renal function, their aldo and renin levels. We also tend to monitor things like left ventricular mass on echo and urinary protein and albumin levels, because LV hypertrophy and proteinuria are much more common in patients with primary aldo than essential hypertensives, and they tend to get better quite quickly and significantly with either surgical or medical treatment. And of course, on the horizon, there are new drugs called aldosterone synthase inhibitors, for example, baxdrostat. AstraZeneca is looking at this drug and planning at this moment a trial of baxdrostat in patients with primary aldosteronism. And I think that's going to be a real break forward. A lot of our patients are quite disappointed when we put them on spironolactone rather than curing them. And the first thing they notice is that their aldo levels go up rather than down, because you're blocking the effect of aldosterone, which unsuppresses renin-angiotensin, which puts up the aldo level. These drugs will do the opposite. They will drop aldo levels, which I think patients will find much more palatable. So in conclusion, PA is a highly prevalent cause of hypertension associated with excessive cardiovascular and renal morbidity compared to essential hypertension. Specific medical or surgical treatment is highly effective at controlling the hypertension, ameliorates the excessive morbidity, and results in improved quality of life. Verapamil, slow-release, hydralazine, prazosin, and moxonidine can be used to help hypertension control during diagnostic workup for PA. Seated saline suppression testing is superior to recumbent saline suppression testing as a confirmatory test. And adrenal vein sampling is the only reliable way to differentiate unilateral PA, potentially curable by adrenalectomy, from bilateral forms best treated medically. But less invasive and costly alternative nuclear med approaches are on the horizon. Thank you very much.
Thank you very much, Professor Michael Stover, for a very erudite presentation. Invite Professor Leilani Assis, Professor of Medicine, University of Santo Tomas, for the presentation on case-based discussion on primary aldosterone and the challenges from Southeast Asia.
Good evening, everyone. Thank you very much for the kind invitation. I would like to thank Professor Stoa, sir, for a very comprehensive basics and lecture on primary aldosteronism. Through my discussion, I might touch some of the same area of aspects of primary hyperaldosteronism, only to give emphasis on the reason how we manage our case in the Philippines. So I have three major topics. One is just to give basic generalities on the diagnosis and management relevant to the cases I will discuss. And second is case discussion on a 40 years history of a patient and its clinical course with bilateral PA who had unilateral adrenalectomy, and 3 cases with probable cyclical or periodic PA. And the third is diagnostic challenges of PA in Southeast Asia. So issues on diagnosis, this was discussed by Michael. In the Philippines, we do more of saline infusion testing in the supine position for confirmatory of primary aldosteronism, which the procedure is based on impaired aldosterone suppression in PA compared to essential hypertension. And as discussed, there are others recommended, such as captopril challenge test, the fluorocortisone suppression test, and the oral sodium loading test done in Brisbane. So the positive test is more than 10 of the plasma aldosterone concentration nanogram per deciliter. And the recent reviews have shown that there's no difference of the results among these different tests, with a high sensitivity of 85 to 87% and specificity of 87 to 95%. Now, another issue is on the management of bilateral primary aldosteronism. One is lifetime medical only with melanocorticoid blockers such as spironolactone, or or unilateral adrenalectomy, which we call systemic hormonal unloading. We gave this term, which means to unload the systemic circulation with excess circulating hormone by removing the dominant secreting adrenal identified through bilateral adrenal venous sampling. In order to give rationale why we have to take off the other one and unload the system with excess aldosterone, it is because of its effect on the cardiovascular system. So the past studies and publications have shown that oxidative stress, subclinical inflammation, and myocardial fibrosis markers are increased in patients with primary hyperaldosteronism compared to those with essential hypertension. And the levels of these markers decrease after unilateral adrenalectomy in these patients. Another parameter to see vascular effect is aortic distensibility. There is alteration in vascular function in primary aldosteronism as shown in some MRI studies. In patients with primary hyperaldosteronism, aortic distensibility is decreased compared to essential hypertension and controls. So overall, the heart will suffer from hypertrophy, ischemia, fibrosis, necrosis, systolic and diastolic dysfunction, and ventricular arrhythmias that will lead to MI, heart failure, and the vessels will do the same abnormalities that will lead to hypertension. And that's why this was mentioned by Professor Stowasser, that the manifestation of the patients now is not anymore only hypertension, but cardiovascular events at the very first visit, such as atrial fibrillation, non-fatal myocardial infarction, coronary artery disease, and heart failure. So, treatment has been shown to be effective on the two things. In this is a study on long-term effect of specific treatment of primary aldosteronism, specifically showing changes on the carotid intima media thickness. These are 42 patients with primary aldosteronism. 21 underwent unilateral adrenalectomy, and the other 21 is spironolactone. So their baseline CMT was compared with 1 year and 6 years follow-up. So the common carotid IMT decrease with unilateral adrenalectomy by 5.9% versus 1.8% with spironolactone. But on the 6th year, the difference narrowing is less. IMT decrease with unilateral adrenalectomy is 9.4% versus 6.8% with spironolactone. The magnitude of improvement at 1 year was significantly different between the two by 70% in favor of unilateral adrenalectomy. But at 6 years, there's no significant difference at all, and statistically not significant at 27%. So in the long term, both unilateral adrenalectomy and spironolactone are effective treatment for bilateral primary aldosteronism. I will show that example as I discuss the cases I will show you. So why consider systemic hormonal unloading? These are the evidences. It had been shown again by the study of the group of Dr. Stowasser that 51 of the 684 patients with bilateral PA who underwent unilateral adrenalectomy had 15% cure of hypertension and improved in 20%. But the most important of their finding is a decrease in the diastolic blood pressure, left ventricular mass index, and plasma upright aldosterone ratio. This is another report by Yamashita et al. 24 patients with bilateral adrenalectomy had unilateral adrenalectomy, and hypokalemia resolved in 76%. Blood pressure control improved in 65%. In our own case, we had a 47-year-old female who had screening test positive, and by sampling, we were able to show that there was bilateral adrenal problem. But she opted to have medical therapy. She went to the United States. She had eplerenone there, and eventually shifted to spironolactone when she came back to the Philippines. But she continued to complain of on and off elevated blood pressure, even with a good compliance, palpitations, and headache. She eventually opted to have her left adrenal tumor removed. Post-operatively, her potassium improved. She did not need any antihypertensive medications, and there was a clear improvement in her quality of life. So the relevant insights, before I show you the cases for tonight, is one, confirmatory saline load test provides definitive diagnosis and pathway for an optimal management plan. Chronic excess circulating aldosterone leads to direct cardiovascular structural and functional damage without enough mineralocorticoid blockade. Systemic hormonal unloading is beneficial to offset long-term adverse cardiovascular events due to excess circulating aldosterone. Now let's go to the discussion of a real-world primary aldosteronism cases in our clinic. She is a 64-year-old female who came in for the second time in my clinic because of generalized weakness. I saw her in 1996 with a blood pressure, with a hypokalemia and blood pressure of 160 to 180 over 90 to 110. She underwent screening and it was positive. And when I did the venous sampling during the time, and it showed bilateral, CT scan actually showed node masses on both sides, and sampling showed bilateral primary aldosteronism. Here is her hormonal studies, and this is her sampling, and with a dominant left adrenal. So we removed her dominant adrenal, and there's adrenal hyperplasia. This actually is a very, very old paper that she was able to find at home, and she gave it to me prior to this presentation, and I was happy that it really showed the result of hyperplasia. She went home with spironolactone, KCL tablets on and off, and calcium blocker. So in the interim, she just followed up with her cardiologist, and recently started to complain again of recurrent hypokalemia. Apparently, in her, you can look at her blood pressure, they were all good. But suddenly, she started to be stopping her spironolactone about 2016 to 2017. And she's starting to have uncontrolled blood pressure, and you can see the serum potassium to be low. So in September 2023, she was referred back to us. I had to work her up, and her symptomatology recurred. Look at her potassium coming down to 2 to 2.5, and I combined her antihypertensive drug with beta blocker. So here is her when I did the screening, I had to repeat all of them. Surprisingly, I got 5 in the ARR. And so we had to do the confirmatory test because we had that history that she was bilateral in the past with hyperplasia, and lo and behold, we got a positive result with the confirmatory test. So patient now was placed on medical treatment maintenance with antihypertensive drugs, CCB, and beta blocker and spironolactone, and advised to improve compliance in clinic visit. So I realized with that 40-year clinical course experience with the patient that spironolactone alone, spironolactone is very, or mineralocorticoid blocker is very important when we follow up the patients. The next 3 cases are showing and emphasizing the importance of confirmatory saline loading tests in diagnosing primary hyperaldosteronism. The word cyclical, I don't actually use that in hyperaldosteronism, not until again I encountered these 3 cases. My PhD paper was on cyclical Cushing, not aldosteronism. So this is something that probably will challenge us endocrinologists and everybody on the field of primary aldosteronism. So cyclical adrenal aldosterone secretion is a periodic fluctuations in aldosterone levels due to a combination of cellular, molecular, and systemic factors, which are oscillatory activity in zona glomerulosa cells, regulation by angiotensin II, plasma potassium levels, and circadian rhythms. In cyclical aldosteronism, phases of excessive aldosterone secretion can lead to one, elevation of blood pressure leading to renin suppression via negative feedback. Two, conversely, when aldosterone levels decline, blood pressure may drop, triggering increased renin release to restore equilibrium. This cycle results in intermittent renin elevations as the body compensates for fluctuating aldosterone levels to maintain homeostasis. I probably did not at all entertain cyclical aldosteronism because most of the cases that I encountered are chronically hyperaldosterone phase. In chronically hyperaldosterone phase, that the renin suppression is really will take time to recover. So I looked at other reports, and this is the only one that I saw, a report by Dr. Senanay Yake et al., who also showed that there is possible intermittent primary aldosteronism when they found the test that was made them entertain intermittent secretion is the confirmatory saline infusion test. Initially was low, was negative, but on repeat, it already gave a positive result. And they were able to show it that the patients had primary aldosteronism. So let me introduce to you our three cases. The first case is actually the one that I mentioned earlier. The second case is a 51-year-old male. And the third case is a 24-year-old male that I just saw 3 months ago. So at current consult, they are hypernatremic, hypokalemic, probably on the low side, even if they are normal. The initial ARR was not conclusive and not diagnostic, but on IV saline infusion, they were positive. During that time, I looked at their PAC and PRA because we repeated that during the screening, during the saline infusion test. And this is where I saw that the initially low PRA was already a bit on the high side. So, and the ARR improved in patient number 1, but not on case 2 and 3. Because of the high degree of suspicion, we did bilateral sampling, and this one I have already reported to you. And case 2 showed bilateral hyperaldosteronism. Case 3 is a candidate for BABS. Treatment, unilateral adrenalectomy, histopath confirmed. And on the second case, he had unilateral adrenalectomy and histopath confirmed. I think it is an eye-opener for me that the CV profile of this 40-year-old history patient after unilateral adrenalectomy, as long as you put them on MR blocker, the cardiovascular system can be preserved. Her ejection fraction was 70% with a good wall motion and no akinesia. So the last topic, so first the insight. Reliance on single time point testing may lead to failure to proceed to confirmatory testing due to aldosterone level variability due to cyclical aldosterone secretion in PA. Repeat or confirmatory testing should be considered in patients with high pretest probability like young onset, refractory hypertension, and unprovoked hypokalemia. So I will finish up with the last topic, which is the challenges in the management of primary aldosteronism in Southeast Asia. This is our report that we published last year. So the objective is to assess the availability and affordability of healthcare resources for managing PA in the Association of Southeast Asian Nations, specifically low middle income countries. The questionnaire This is a questionnaire-based survey to specialists, 48 respondents, mostly endocrinologists from 9 ASEAN countries. So if you look at this figure, the the blue color are countries who have routine performance of confirmatory testing, while the red not performed due to inability to afford, lack of availability of facilities or assays. And unfortunately, they are servicing 100, 345,000 million community in their countries. So next is access to adrenal vein sampling. Again, if you look at the red, majority cannot perform it due to inability to afford, lack of availability of facilities, or no assays. So 9 ASEAN country members participated, while screening with aldosterone ratio is performed in all. Confirmatory testing is routinely performed only in 6 countries due to lack of facilities and local assays and costs. Assays are locally available in only 4 countries, and some centers have a test turnaround time exceeding 3 weeks. In 7 countries, adrenal vein sampling is not routinely performed due to insufficient radiological facilities or trained personnel and costs. Most patients have access to adrenalectomy and medications. In 6 countries, the cost of AVS and adrenalectomy combined is more than 30% of its annual gross domestic product per capita. While most patients had access to spironolactone, it was not universally affordable. So the study conclusion showed that in ASEAN countries, large populations currently do not have access to the healthcare resources required for the optimal management of primary aldosteronism. Greater efforts are required to improve healthcare access and affordability. Future guideline revisions for primary aldosteronism in this area may need to be considered because of these limitations. This is my last slide. Thank you very much for your kind attention.
Thank you very much, Lani. That was a very nice presentation and a great compliment to what we heard previously from Professor Stowasser. And now we're going to have a case-based discussion, and it's my pleasure to have Dr. Krishna Sheshadri come and serve as presenter and discuss.
This one. Okay. Thank you. Thanks for the opportunity, Dr. Singh and colleagues. What I thought is, if we can have some mics for the gentleman and the lady there, it'll be good. So, and also, what I've done is I've made it sort of interactive. You can actually whip out your phones, just scan it, and it'll lead you to Slido. And this can be a very interactive session. Phones out. I'm the only speaker who's going to say, keep your phones out. Got your phones? Did you get it? Got it? Ready? Good? Shall we go? Okay. So here is a patient. A 35-year-old woman is evaluated for new onset hypertension. I've kept this simple, but we will make it difficult for the panelists and get tease them out. Shashank, where are you? She had hypertension in her second pregnancy, but delivery and postpartum have been uneventful. There's no family history of hypertension. She does not smoke. She does not, there's no substance abuse. She does not use OCPs. This is her body mass index. Waist is about 88 centimeters, which is high for India. Blood pressure is 160 over 100. Her EGFR is 96. Potassium is 3.5, bang in the middle. And ECG is normal. Fundus, no changes. Her screening echo, which was done, was no abnormalities. So here is the question. For the audience, you can answer this again if you want to. So which of the following represents your understanding of this? Should she benefit by testing? Maybe, but because the guidelines are talking about universal screening, even though I don't think it's hyperaldo, I'm going to do it. No further testing is required. Yeah, 2 people, 4. So because this is a hyperaldo symposium, I think we have about 70% saying that you should test. We're good? Okay. So let's ask the experts. Dr. Srivastawa, you think, let me start Dr. Srivastawa and then we will use, so do you think that in this particular patient, in a resource-limited primary hypertension setting, should there be routine screening for hyperaldosteronism?
Well, I mean, yes, I do. I think that the outcomes for specific treatment of primary aldosteronism really warrant a good look for this condition. And it's not just outcomes in terms of immediate improvements in quality of life, it's also long-term benefits in terms of cardiovascular and renal morbidity. Her potassium was a bit on the low side, so I think that would put her in a higher risk category for having primary aldosteronism. So, yeah, I think I would look for it. In fact, it's routine for our hypertension unit to screen every hypertensive for primary aldosteronism.
So that brings us to the Philippines. And
Can you
and you
bring
just
back-
showed us, yes.
Can you bring back the table?
Yeah.
Okay. So whenever I see a hypertensive patient, I always get a paired sodium potassium because if I have a sodium that is not 140 or it's low, I won't prioritize primary aldosteronism. For somebody coming from a country that I have to think 3 times, 4 times where to put my screening is, I'll get to the other side. So I use sodium actually a lot of time if I want to go to FIU first rather than primary aldosteronism. That's one. Number 2, the fact that the fundus are still okay, it may signal 2 things. One is the hypertension might be cyclical or it's not there. It's 160 for a long time yet, or that her hypertension is recent and that there's no other organs affected. That's all.
Shashank, you want to?
I tend to agree with we are endocrinologists here, both of us. I think we have resource constraints. So if I'm seeing this patient who can't afford anything, the question is a very good. So actually, where you see the patient. If you're seeing them in a private practice or a large tertiary care referral center in public hospitals, probably the answer is yes. If you're seeing them in a poor clinic or a primary healthcare setting where we don't have resources, the answer is no. I still would go by Michael. I think it's time that we have an heightened education and sensitivity. I think it's time to screen. It's worth the screening.
Okay. Any comebacks?
No, I'm happy with all of that. I'm acutely aware that we've been doing this for so many years that we're in a situation where, in fact, the GPs are already looking for this. And I'm also very aware that there are going to be challenges associated with trying to apply this on a universal level. But as Krishna said, if we don't make some effort to do so, then we'll never address the problem. And so heightened awareness and trying to improve resources in this area is something that's long overdue.
Okay. I'm just going to move on and, complicate this a little further, also highlighting some of the issues that people look at. Let's take another person, a 36-year-old woman who is undergoing treatment for primary subfertility. By the way, all of these are real patients. Was referred because she had abnormal lab tests following workup for hypertension. Her current medications include a combination of cyproterone acetate and an OCP. Diene 35, a lot of people use it here. Based on the values obtained, she had a CT abdomen done, which is normal, no bilateral hyperplasia, no nodularity, no granularity. Her plasma aldosterone is 50 nanograms per mils. Her direct renin 0.1. Blood pressure was 140 by 95. EGFR is 102. Potassium was 3.5. There was no lesion detected. The reason I bring this up is while both your presentation talked about plasma renin activity, many of the labs in this country and everywhere else have started doing direct renin. So let's go into this case. But first let me ask you the questions. PRA versus direct renin, what would you use? And then we could get back to the case.
Yeah, well, I would love to use plasma renin activity in Brisbane, but we don't have it anymore. So we have to use direct renin. In patients who are on an oral contraceptive pill, combined estrogen progesterone 1, we tend to find that using direct renin is more likely to cause false positive aldosterone to renin ratios. And that's because in the situation you've got progesterone on board, that will block mineralocorticoid receptors because it is an antagonist. This will ramp up the renin-angiotensin system. So you find the PRA goes up as well as aldo going up. Now, what you don't find is that the direct renin goes up as much. And that's because the estrogen component of the OCP leads to an increase in angiotensinogen amounts, the substrate. And in order to prevent excessive production of angiotensin 2, there's down regulation of the renin by the kidney. So you get less renin being produced. And because of that, you get a rise in the aldo-renin ratio. Now, in this particular patient, if you could go back to the previous slide, she's got an aldo level of 50 nanograms. Hang on, that's nanograms per mil, isn't it? That's not nanograms per deciliter. So actually, that's a fairly lowish aldosterone. That would be 5.0 nanograms per deciliter. So that's starting to make it look less likely that she would have aldosteronism just based on the absolute aldo level.
Just to add, I just had three weeks ago a patient who was sent to me saying primary hyperaldosteronism with the CT that's normal, and actually the issue was that they had read the nanograms per mils versus nanograms per deciliter. So when you look at aldo, you find that various labs use various. Some people use picomoles, some use nanograms. On top of this, the direct renin and the PRA tronin don't see a hyperaldo patient in the middle of a busy clinic. This is from someone who's been burned before.
The only other thing I wanted to mention, though, is that direct renin level is much lower than what we see in patients on an OCP.
Yeah.
So the classic pattern of aldo and renin in a patient on a combined oral contraceptive is you have a high aldo level, which she doesn't, and you have a mid-normal renin level, which she doesn't.
So, but that does vary depending on the week of the OCP. So, around about the third week, you should have a higher aldo and a much lower renin level. But the reason I pointed this out is, remember that the PRA level will actually go up with OCP, but the direct renin level will go down with an OCP. So if you've done a PA-PRA level, a PA and direct renin level, you can get a false positive where someone has done this and sent it to you. So we just took her off the OCP, repeated the PA-PRA level, and then we have access to PRA, so we did it and showed that this was okay. But the other point is that should we move away? I don't want to get into drug interferences because I think that's a whole topic on its own, but should we move away from the ratio? We have been learning about using a ratio of 30 and a ratio of 20, but is it time to start using paired values? I'll put up the table and maybe all of you can comment on it. Do you still use ratios in your practice?
Yes, we do, but I think I'll be very quick. But I think it is important to look at the components. A good example is beta blockers. So you might have a high ratio, but that's because the renin is so incredibly low, and you only have to quickly look at the aldo level to see that it's also quite low, and then you know that it's just a beta blocker effect. Similarly with OCPs, you might have a high ratio, but that's purely because of high aldo. The renin is usually sort of mid to lowish normal. So that's two good examples where it's good to look at the actual components.
Shashank and Dr. Lee, do you use ratios anymore, or have you started using paired values?
I still think we need a little bit of both ratios and we have actually AI-based algorithms now use the paired values better because the drug interference is very tough. It's very difficult to stop agents for 4 weeks or 2 weeks and start them on the other agents which don't interfere with the so I think we need, but I think we can't do away with the ratio. At least for the message to primary and secondary care is we can't do it. That's my take.
Can you bring the table again? Okay, so the looking at the patient, we have to investigate further of the symptomatology because that will add up to our pretest probability of the symptomatology of the patient. Number one, I was looking at your numbers. I think you have pointed out that you have to be very careful on the units, the laboratory used, and interpretation. The 0.1 is too low for a low PA, even if it is probably deciliter. So, I mean, if I look at it, it smells PA because of the ratio of more than 20, just eyeballing it. But the most important in this table is showing a normal kidney function. So in assessing your numbers, be sure that the patient's kidney function is normal because it's very difficult for a primary aldosteronism at least because it's very difficult to interpret if the kidney function is already affected.
Fair enough. So just 2 points, traditionally somewhere in the 2000s we were talking about, don't worry about anything, just get the PA-PA ratio, PRA ratio. If it's more than 30, then you're home safe. If it's between 20 and 30, go ahead and do a serine loading. I think some of these are being challenged over a period of time. Look at the units carefully because many labs report it differently. Be careful about, and when this thing, please use this kind of a table which gives you a paired value. And remember that many labs have stopped doing PRA and they're using direct renins, and that's a very, very tricky thing because it's not standardized also. Yes.
Now, just a small comment. One of the reasons the renin is very low is because of the cyprotron acetate. Because cyprotron acetate is known to suppress
It does.
and have almost at zero renin. So the renin level in this case was low is not just because of the OC component, but because of the cyprotron.
So in fact, I have 3 patients who are on cyprotron acetate plus this thing, who have had, because of blood pressure, PA-PRA ratio low. You take it off at just goes up. So, and there are a couple of publications already on this. Okay, so let's go to the third patient, which is the last patient, but hopefully this brings up the next level of complexity in this. Here's a 44-year-old man admitted for fatigue following start of an antihypertensive. Remember the reason, this is, he's on 12.5 micrograms of hydrochlorothiazide. The admission potassium was 2.8. PAPRA was obtained. That should be deciliter, I'm sorry. It was high. Blood pressure was 140 by 100. The CT shows a 2 by 1.8 centimeter lesion in the left adrenal. Focus on the CT. It had the Hounsfeld unit was 26. The washout was 96%. So you can tell. So 4 options: surgery, medical therapy, adrenal vein sampling. Patient had a confirmatory test, had a saline loading, so it is hyper. 2 people. Answers? Okay. Evenly matched. All right. So, would you, at what level of confidence would you send a patient for surgery without having an additional test telling you that this is just a red herring? Maybe we'll start. Ma'am, you, and then
Can you show the table again?
don't go to the table. You have a lesion. Move on.
Okay. The lesion is not that big though.
Yeah, exactly.
There's
why I
a
want.
rule that if you're like 6, there's no question to remove it, regardless if it is non-functional because of the problem of malignancy. I don't feel comfortable not to do sampling because the discordant report on imaging and something is somewhat high for me, and I'd rather do the sampling before doing anything else. Because again, it's the Hounsfield.
The
What
Hounsfeld
e-
was 26 units. One second. I'll get you the HU here. Yeah.
So it's 26, and it's not. It's a
And
little
the
bit on
contrast
the
is
high
about,
side.
it's a CT contrast, so 96% washout.
Uh-huh. So that's the red herring there. The question is, do I still have time to observe that that adrenal finding in the CT? But as far as PA is concerned, I'd rather do something first.
Dr. Srivastava, you.
Well, yeah, protocol would be to do adrenal vein sampling first, but I think this is one of those situations where, you know, the issue as to whether the resources are there, the expertise is there, and if it's not, you know, you'd have to be pretty confident that this is going to be left-sided unilateral primary elbow due to that lesion. So I would support removing it if AB sampling is just simply not available. But I always prefer to do it because once that gland comes out, you can't go back. It's gone. And if you find out you haven't fixed the problem, well then, you know, you want to do sampling before I made this final decision to remove the gland.
At what tumor size would you say, look, I really don't need to look for concordancy?
Yeah, we generally get edgy about tumours that are reaching 4 centimetres. My mentor used to get itchy in the fingers if it was 2.5 centimetres. Most people probably it's a little on the low side. I have seen a pathological slide of a adrenal carcinoma that was invading the IVC at 2.5 centimetres, but that's exceedingly rare. So yeah, I think 4 centimetres is about my cup.
Shashank?
In India, we have a challenge having adrenal vein sampling. See, the standard of care is adrenal vein sampling. Absence of that, probably this is a case where you will either do aldo blockade followed by surgery. but the size doesn't support surgical option unless adrenal vein sampling is absent. So there's there. Nuclear medicine you put out us, and I saw a lot of people putting that out. I want a little elaboration, Krishna, on other nuclear scans which are available.
So one of the
So I
things
thought that's another option which we have in absence of centers which don't have adrenal vein. Now, so I'm from Bombay. We do have access to adrenal vein, so probably at my center I would go for adrenal vein sampling. But in other parts of India where I see cases, they sometimes do a nuclear scan in these cases. So would like to elaborate on that.
so I think that Stovasa talked about having a cyclotron in your own place, right? So the other option that I've seen people use, and I use AWS because you have option to it, but this particular patient said, I don't want to do it. You give me another option. And so this is just representative image. I just put it up because I want people to know. But in Chennai now, we have gallium-68 pentaxophone. And it's an option, and there's increasing data to show that there is good concordance. I know if you have any experience with it. Yeah.
We don't, but I entirely agree with you. In Australia, we don't have metomidate, we don't have pentaxophore, and we don't have aldovue. But these are all things that we are pushing to try and get on board. There's a very active researcher in Melbourne called Jun Yang, who has research money to try to look at these particular techniques. I also wanted to bring up what you said before about the patient didn't want AB sampling. I think that's extremely important because, the patient's wishes at the end of the day are paramount in whatever decision is made. They're the boss, they're the ones that make the decision, and all we can do is provide them with the best advice that we can give them. So yeah, I think that would be another reason if a patient said to me, look, I've read my stuff, I know that this is almost certainly a left-sided tumour producing aldosterone. Do we really have to do AB sampling or drug? It's not often we hear that though. We find that most patients are keen to have a definitive answer before we make a definitive decision about management.
Well, this patient was related to a nuclear medicine physician in Tata Institute of, which is exactly why she had this done. So just to move on, so by the way, this is available in Chennai today if you really, I think we discussed this. But the question is, let's say this patient came back and said, look, doctor, I understand, but I've also heard that medical therapy is fine. And how long can I just go on medical therapy without going into surgery? Is it reasonable to offer such patients medical therapy? And if yes, how long can we do that? Let me get from each one of you.
If I may answer that first, I think this is the time that we have to individualize cases. In my report, I have shown that in this 67-year-old diagnosed at age 37, she was good with spironolactone. Her 2D echocardiogram 40 years later was still good with a 70% ejection fraction. But for those patients with cardiovascular impairment or problem already, we have to think twice. But yeah, after seeing that 40-year-old clinical course, I have shown that spironolactone, you can accede to the whim of the patient that he will be on medical therapy lifetime.
What, Dr. Stovasa, what is the experience with finerenone or eplerenone?
Well, eplerenone, yes. Finerenone in Australia, again, is not approved for use in primary aldosteronism. And in fact, neither is eplerenone, believe it or not. And so patients have to pay for it, unsubsidized. It works out to about $1 to $2 a day for the patient. It's not terrible. So yeah, we do have that option. And it's interesting with regards to the patient's whim, as Lani put it just before, as to whether they want surgery or not. There are some patients who would choose not to want to go through adrenal vein sampling and not to have surgery. funnily enough, it's often doctors that make that decision for whatever reason. So I have quite a lot of colleagues who've opted to be on the coronary because they can afford it, and not to undergo adrenal vein sampling surgery. And that's perfectly fine. I think predominantly for the milder primary aldo patients, but when you've got rip-roaring primary aldosteronism like this last person did, then, I think they would do much better with surgery compared to small.
So if you see LVH, or if you see that they're coming to the hospital with more hyperkalemia or failure, you tell them, better get this.
Yeah, I would, but on the other hand, you've got to be very careful that they're good surgical candidates. And one of the things that we do routinely now is once they've had the AB sampling, it's lateralized, we put them on spironolactone leading up to surgery for at least a few weeks. And that way, by the time they come to surgery, they have a smoother perioperative course, their potassiums are okay, their blood pressures are okay, and it may improve their cardiac functions.
Last comment from, yes, Shashank.
I think the biggest problem is that countries like India or Asia or Philippines is adherence, compliance. What happens is many of our patients don't opt for surgery, including doctors. I completely agree with Michael. But the challenge is that minute they are, I think she showed a beautiful case where minute the potassium normalizes after 3 or 4 years, they just stop therapy, they stop seeing the doctor, then they'll end up with a catastrophic cardiovascular disease. That's the challenge. I think therefore, if they are able to follow up regularly, at least in resource limited countries, particularly government hospitals, there is no follow-up. Therefore, that is the challenge which I see. Otherwise, it's an excellent option as long as you do adequate aldosterone blockade, and that adequate aldosterone blockade is not easy. So that's the challenge.
So Dr. Narsingan is already showing me a timeout. I'm just going to open it for 60 seconds for questions. You could type it in or you could ask us. Yes. Yes, Dr. Parna. No, there was only a unilateral change.
Yes. Whatever it is, it's a primary arterial hypertension. Thiazide was used in that, but thiazide is supposed to worsen the symptoms of primary hypertension. So
Correct.
is it
The patient was detected because somebody had started thiazide in someone who was presented with hypertension.
so? That's ideally that is not the drug for the thing.
Do you know that many people are diagnosed because they started on a small dose of diuretic? They develop hyperkalemia, and that's how even the diagnosis is concerned.
Thank
So
you, sir.
it's not just spontaneous hyperkalemia, but minimally provoked hyperkalemia is one of the key symptoms of hyperaldosteronism.
So apart from the
in India, doctor, one of the most common ways we pick it up is because they are started on a thiazide. That's how they get picked up, and that's how the hypo comes up, and that's how the investigation starts. In fact, that's exactly, I agree with him completely. That's what we see in practice.
Okay, treatment of choice for Conn syndrome, surgery, and all the other things that we talked about. Yes. Shall we stop here? Yes. Thank you so much. It's been a great audience. Thank you please give a big hand to our panelists who've done such a fabulous job. Thank you so much.
That was a very delightful and I think very thorough discussion of aldosterone. I'd like to thank everyone who's contributed to that, and particularly Michael and Leilani. Those were terrific presentations. Now on to salt. And I'm going to ask Dr. Kapilani to moderate this session along with Dr. Soni.
Now, ladies and gentlemen, give them a big hand because we had learned a lot on hyperaldosteronism. It is now time to move on to the second session, where the important problem of salt and hypertension will be discussed. For this particular session, we have two eminent personalities. One is President of the World Hypertension League, Dr. Paul Wilton, to chair the session with Dr. Michael Wilber. And Dr. N.K. Soni, who is a physician diabetologist of Lucknow, has agreed to be the moderator for this scientific session. Ghaziabad. I think over to you, Dr. Paul.
Wait a minute. So we're going to start by talking about salt and hypertension, and we will be hearing from Dr. Rajan Ravich Andran, who is director of the MIOT hospitals, chairman of the Supian's Health Foundation in Chennai. And I really want to congratulate our colleagues at Microlabs for their willingness to allow us to discuss something as important as salt, just for our general edification and knowledge. So please, sir, if you're ready to go, we'd love to hear all about salt and hypertension.
If I permitted to add only one point. Dr. Rajat Ravichandran is involved very much in the advocacy on salt reduction. In fact, in 2014, he received an award from World Hypertension League. So that gives me an enthusiasm to put him as a speaker here.
Good evening, everybody. At the outset, I should thank Dr. Narsingan, the organizers of this symposium, Microlab, and World Hypertension League for having given this opportunity to talk in front of you about salt and hypertension. This topic is getting great importance, and salt, as you know, is a very ancient substance. It was discovered 7,000 years back as a preservative. So salt was used to preserve the fish. So you hunt in the summer months, keep it in the salt water, that is brine, to tide over the winter months. So it was a strong preservative, very important substance in the ancient past. The Romans considered it so important that the salary was given as salt bags. The word salt is derived from salarium in Roman. So it is a very important substance. It continues to be still the best preservative. And it is also reducing it is the most cost-effective way of reducing hypertension in the population. Unfortunately, although it was started as a preservative, now it has become a part of our integral society due to the taste that we have developed for salt. If you look at the history, the French physicians were aware of the relationship between salt and hypertension in the 19th century itself. The longest trial was conducted in 1940 by Walter Kemp, who kept persons without salt for more than a year. And he showed there was not only a drop in blood pressure, there was a reduction and reversal of the heart size and an improvement in kidney function. Looking at how salt produces hypertension. Salt is associated with water retention, expansion of the blood volume. All of us know it. The blood volume is then transmitted to the endothelium. Then normally the endothelium, the blood vessel should dilate by producing nitrous oxide, in which case the blood pressure would not go up. That is the mechanism of salt-resistant hypertension. If you give salt and if the blood pressure doesn't go up, it is salt-resistant hypertension. If on the contrary, the nitrous oxide is not produced and the blood vessel fails to dilate, you find that the blood pressure goes up. So that is salt-sensitive hypertension. Basically, this is genetically determined whether you are salt-sensitive or salt-resistant hypertension. But what starts as a salt-resistant hypertension can change with age. So this nitrous oxide production can go down. So although it is genetically determined, age, kidney function, medications can all change the sensitiveness of the blood vessels to salt. So what is the evidence that salt is connected with hypertension? There are more than 50 studies which have shown, epidemiological studies. The most important one, I'm sure all of you are aware, is the InterSalt study, which showed in more than 32 countries, more than 10,059 patients, males and females between 20 and 60 years, there was a direct linear relationship between systolic and diastolic blood pressure and the salt consumption, which was detected by using the 24 hours sodium measurement. Very important test to know the salt intake of a person. So that was the most important InterSalt study which showed the relationship of salt and hypertension. Obviously, there are interventional studies, genetic mechanisms which I alluded to, the salt sensitiveness to hypertension, animal experiments in chimpanzees, treatment meta-analysis, mortality studies, population studies, all attributing salt and hypertension. The South American Indian, this man is a tribal man who has no exposure to salt at all for generations. He has all the stress because of predators, because of tribal wars, but still he is never exposed to salt. His average blood pressure in the tribal is only 96/61. Cholesterol is also low. He has access only to natural food, very little meat, more of vegetables and fruits. No vascular disease. Even at his ages, he doesn't have vascular disease or hypertension. Of course, they die of infections and due to deaths due to animal bites. Chimpanzees. If you look at one of the earliest experimental studies, chimpanzees which are normally don't eat have access to salt in the jungles. Once they are urbanized and they are fed the human salt, what the humans consume, about 10 to 12 grams of salt, over months, 6 months, 14 months and 20 months, the blood pressure what starts with 100/60 lands up with 140/90. Meta-analysis. These meta-analysis studies have been there both in normotensives and in hypertensives and have shown that a reduction in salt is associated with a reduction in blood pressure. Japan was the first one. In 1960, the government of Japan took a campaign to reduce salt because Japan was having one of the highest salt consumption in 1960s of almost 18 grams a day. So from there, it was brought down to 14 grams. And with that, there was not only a drop in blood pressure, there was an 80% reduction in stroke mortality. At that time, smoking was still rampant in Japan. Finland. Finland also is one of the early countries which had a program for reduced salt intake, and they showed a reduction in diastolic blood pressure and a stroke mortality. If you look in the last couple of years, there have been a number of scientific papers which have come out. And I looked up almost 20 papers have come out in the last 2 years of correlating to salt and hypertension and reduction in stroke, cardiovascular mortality and chronic kidney disease. Of course, this has also been due to the WHO warning in 2 years back after the post-COVID that countries have gone derailed from the pathway of campaign of salt against non-communicable diseases. So even a small program like a self-performed dietary sodium reduction. So what they did in the Danish study was a telephonic conversation and for half an hour educating on reducing salt, and this was followed in one group for 4 weeks and in another group they were allowed to take the normal salt, and they could find there was a reduction in blood pressure almost to 6 millimeters with this. Community-based intervention also in hypertensive patients. Guidelines and use of promotion low salt intake in China. This was after the study where they showed the use of low sodium salt substitutes reduced the mortality of strokes. Of course, commonly used salt substitution associated with a low mortality, high salt intake linked to increased salt intake for kidney disease. Again, in China, it was shown that higher salt intake was associated with increased protein leak. The salt intake is associated with a leak of protein in the urine. This is very interesting. In our language, local language, the Tamil, salt, the word salt is used both for protein and sodium, the common salt. So patients always come and tell you that they are leaking salt in the urine. What they mean is protein leak. But China, they showed studies which showed proteinuria is linked to salt intake also. So a recent study which showed by reducing salt intake in a short period, even 2 to 4 weeks, there is a drop in blood pressure. One of my colleagues saw the advertisement. He's a professor in IIT, and he saw the advertisement of the American pistachio for vegetarian to improve the protein intake. So he took for the next few weeks 100 grams of pistachio daily, and after 4 weeks his blood pressure went out of control. Then he realized the pistachio was all salted and he was consuming very high salt in 4 weeks. So there are adding salt to foods has had premature mortality, effective treatment, several papers that have come in the last 2 years. So all of us know what is the recommendation by the WHO. 5 grams of salt from all sources. Natural salt, salt added during cooking, and salt that is present in the hidden salt that is preserved in the packed or packaged food. So I'm not trying to talk about the confusion of sodium and salt, because this is important when we label for the common man. But suffice to know that 2 grams of salt is equivalent to 5 grams of common salt. Normally, the sodium is responsible for the hypertension in the salt component. But what I saw interestingly in the couple of 2 papers from China again, that chloride also has a role in hypertension. So how to bring down this salt from 12 to 5 grams? Reformulation. The mantra is reformulation. Reformulation at home. So use less salt at home. Reformulation in eating out or procurement. Government agencies which procure mass meals, there should be a reformulation. And of course, reformulation in the food industry. So reformulate to bring down the salt. Educate the public that salt added is a slow chronic poison which puts up your blood pressure and a major cause of death and disability, particularly strokes. Use less salt and salted products. Schools, communities, continuous TVs, videos, and other public campaigning. Obviously, salt added by the industry is very important, and it is gaining importance in India, although the salt intake in India has been shown to be more during cooking, but packed food is gaining importance with modern urbanization. Of course, I'm not going into the details of labeling and tax on salt, etc. I run a foundation for the last 27 years, and our program from 2010 has been on reducing salt intake of the Indian population. Dr. Narasimhan already alluded to the fact that we got the Notable Achievement Award by the World Hypertension League in 2014. This is a walkathon we started in the beach in 2010 in Chennai, in Pondicherry. Specifically, I'm mentioning Pondicherry because this is the only state in the whole country where low sodium salt substitutes are used more because of the effort of one physician who has made it available to the population. Of course, in Trichinapalli, we have several posters where celebrities talk about salt, videos which we have released. The Vice President of the country gave a message. We have street plays which we take them to the slums. People think that the poor people don't have hypertension. Poor people consume a lot of salt and hypertension is a problem. Street plays in slums again, where we try to educate them. Of course, if we had a world international conference in 2017 when Professor McGregor from the WASH chaired the session and Soumya Swaminathan of the WHO was present. This was conducted in IIT Madras and IIT Chennai. We had the New Year resolution to avoid the salt shaker. We campaigned to the restaurants in Chennai, asked them not to keep the salt shaker on the table. See, the habit is if there is a salt shaker, if soup is served, even without tasting, people add salt to it. So now about 200 restaurants have kept the salt shaker away from the table. And of course, we had essay competition in schools, children, where they are given prizes for essays on salt, a very popular program. And of course, the World Healthy Kidney Day, we celebrate again because it falls during the World Salt Week. The next week we have the World Salt Week and the World Kidney Day. And posters we released with celebrities. Again, the superstar talking on salt intake, which is a very popular video we have. And of course, we launched the Low Salter organization 2 years back, where both physicians and lay people have become members. Again, with the Directorate of Public Health, the Tamil Nadu government has been very supportive. 2,500 physicians we have interacted, and we have now the government has sent a circular for the use of avoiding salt, which is not iodized, and create an awareness about low salt intake. We had the workshop for physicians in IIT Chennai, as well as we have had it in Mumbai. Dr. Narsingan also took part in it. And I'll conclude with my talk. We would like to be like the chimpanzees in the wild, have a low blood pressure rather than the urbanized chimpanzees. Thank you very much.
So, Dr. Ravichandran, that was a wonderful talk, and congratulations on everything that you have done over the years and what you've achieved. So there are three major approaches one can take to try to reduce salt. One is educating and trying to change behavior, always difficult. And in the studies, I was involved in a lot of the National Institutes of Health studies, where we have very good teams trying to work with our participants. And we could achieve in almost all of those trials about 25% reduction. You don't get as much, at least in the US, we don't get as much when we're not using those teams. So it's really important, but it's really difficult. I think we both agree on that. The second approach is policy, trying to get governments to influence the manufacturers and processors of foods not to add so much sodium. Depending on the
country, that can be very valuable. It's potentially very valuable in the US, but it's almost impossible. It has proven to be very difficult to get policy changes. Some countries have been much more successful, and of course, countries that don't eat too much processed foods, it doesn't work so well, but it's a good strategy. The third one I really want to quiz you in this is, you mentioned it, salt substitution. And yes, one can substitute usually up to about 25%, typically with potassium. With higher substitution, it's not very palatable, it becomes astringent. And you mentioned Finland, and in Finland, they moved to salt substitute many years ago. They use pansola, and it's almost all of the salt in Finland, both for baking and the salt that is used at the table is pansola. Most other countries haven't moved as much, but you mentioned the cluster trial from China, which was a really good example of a cluster trial, 600 clusters, 300 intervention, 300 control, and showing very potent reductions in all cardiovascular outcomes and all-cause mortality. So it's a pretty good proven track record. And my question to you then is based on cost. How practical is that? That seems to be big focus of interest now for everyone who's involved in trying to reduce sodium as very practical and tangible means of trying to reduce sodium. So I'm wondering.
Yes, we have been interacting with physicians and public. Unfortunately, here there is first the concept of a low sodium salt substitute is not there. In the sense they think salt alternatives like the rock salt, Himalayan pink salt are actually salt substitutes, which are not, which contain high amount of sodium. So they really don't matter. So what we talk of low sodium salt substitutes are potassium chloride, which is in India, we have two types of salts available, two companies, where we find 20 or 40% of potassium chloride. As you said rightly, with 40% there is an after metallic taste. It's not been very popular. The 20% again the cost is 3 times the normal salt. So it's been a little difficult problem, and only couple of companies manufacture. And about our surveys showed that only 30 to 40% of the physicians are aware of low sodium salt substitutes.
Dr. Rajan, I would like to compliment you for all the work which you are doing as far as the salt substitution and low salt and the awareness among the physicians and the general public is concerned. But then I was coming to that question that commonly in our clinical practice and in our Indian scenario, the public, the villagers, they opt for the alternative salts. Means whenever you ask the patients to take little less salt, they'll start saying they are taking sendar namak, and they were saying that rock salt they will take the low salt which are available in the market. Probably they are not having a low sodium as such, and then even so the question again is how to convince them that the senda namak and the other salts also are equally bad for taking this to reducing the salt intake.
Again, it's a matter of education. But interestingly, that you pointed out, we had a discussion and programs with the Directorate of Public Health in Tamil Nadu, the government. The government had sent a circular to 2,000 primary healthcare physicians, writing to them that rock salt should not be encouraged for consumption because they can also get an iodine deficiency, because these rock salts are not iodized. So again, low consumption of less salt of an iodized salt is safer than taking rock salt. But to percolate low sodium salt substitutes is more difficult. That it is going to be potassium chloride. I'm sure if the cost comes down, it could make a difference. Right now it is 3 times. In India, the cost of 1 kilogram of salt is about 20 cents. So whereas the cost of a low sodium one would be 3 times. It's almost $1 or little more.
Yeah, one more question. We all know that reducing the salt definitely reduces the morbidity and mortality, cardiovascular mortality. But then again, it's a J-shaped curve where if we reduce the salt to a very significant level, even then the low sodium also causes a little increase in morbidity and mortality. So how are we going to describe and to convince the patient that how much to take and how much not to take?
See, normally hyponatremia, what you are referring, is not seen unless the water intake is unrestricted. Normally it happens only when you take a diuretic. When you take a diuretic, the free water clearance of the kidney is affected. Otherwise, if you take water, the kidneys will remove it. It's called free water clearance. But in the absence, if the kidney function is not good, or if you are taking a diuretic and you reduce salt intake and you have access to unlimited water, your sodium will drop. You will get a hyponatremia. So it's always, you should look at the kidney function and the use of a diuretic when you are recommending a low salt, and a simultaneous water restriction may be advised.
Shashank, any comments from your side?
I think it's a great talk. I think what Dr. Soni was alluding to is sometimes very low salt can also aggravate insulin resistance. But I fully agree with you that the consumption of salt in India is so high. It's almost 5-fold than what we are supposed to have. And our biggest challenge is the invisible components where there is salt, like pickles, chutneys, papads, the foods. And I think we need to hit hard. I congratulate you for your public advocacy. I think we all are one in this movement. I'm also a big proponent of restricting salt and sodium. And I think I completely agree that what Paul was alluding to, that we need to make this and further compel our manufacturers and policymakers to restrict. Particularly, there is a free flow of foods. Particularly, people are not cooking at home. They are ordering foods from Swiggy and Zomato, which are all ultra processed, and all the ultra processed foods have very high component of salt. Preserved food is back, and that's a big, huge problem which we're having. So we have a dual jeopardy. In rural India, we have the papads, pickles, and the chutneys. and we have the foods which are there. So I think we need to continue the movement which you are doing. I congratulate you for that.
Thank you. Actually, one of the biggest problem in India is instant noodles. The instant noodles contain very high salt, and we wrote to about 300 food manufacturers trying to request them to reduce the sodium component in the manufacture. Of course, out of 300, only 2 replied. 298 did not reply. Our letters went down. But fortunately, the most important one, the Maggi noodles, they have reduced the salt. So that's been a good achievement for this country.
Thank you for the nice talk. Maybe the most important thing is to coming back to the diet of the chimpanzees. Because the problem now is the food industry. If you want to sell more, put more sodium. It is the way. Maybe it is not a good idea to recommend only restriction in sodium, but also increase the intake of potassium. That means coming back to natural food, more vegetable, more fruits, less industrial food. And maybe it is a good recommendation, because if the recommendation is only decrease the intake of sodium, the results is that nobody accept this recommendation. We need a lot of effort to that. Maybe if we started to recommend a healthy diet, we will have good results.
Absolutely. I think the potassium intake should be increased in natural way with fruits and vegetables. The ratio is very important.
It was a wonderful talk, sir. But what surprised me is that we generally talk about reducing or stop eating refined stuffs, whether it's white sugar or even white salt. I always thought a rock salt, which has some impurities, some minerals, even some earth content, and so many things. I'm actually surprised to get from you is that both have equal amount of salt.
Yes.
So I always thought that giving the smaller amount of any salt, which is not refined, would be better for most of the people. I wanted more clarification from you.
What he said is that sodium content, which is the culprit.
Yes.
Sodium content.
They are
is
similar.
Quite similar in rock salt as well as in the commercial.
Including Senda Namak, Hindupu,
That's
all
right.
different so-called salt alternates, I would say,
And
available
that
in India.
that is
They are
why-
not salt substitutes.
That is why the quantity is a little more, and that is why these are equally bad. Yes, sir.
Sir, wonderful presentation. Sir, when a normal serum sodium of 145 milliequivalents, the kidney excretes around 1.5 kg of salt per day. That is 25,000 millimoles of salt per day. If you take excess salt, will the salt itself damage the kidney other than producing hypertension, volume overload, heart
Yes.
diseases? Will salt itself deposition in the kidney, will it damage
It is
the
not a salt deposition, I would say. Salt is known to produce endothelial dysfunction. That's the reason for this vascular damage. See, this is again a point which is very important, which people do not realize, that I have a normal blood pressure. Why should I restrict salt? The moment I tell a patient, you require to reduce your salt, they say, I don't have blood pressure. So it's not that you require a high blood pressure to reduce salt, because salt produces endothelial damage. And you know, the maximum endothelium is present in the glomeruli. So the kidney has the largest endothelial surface. So you find if you take high salt, proteinuria increases and there's a damage to the kidneys.
Thank you very much, sir.
Yes. Last question probably. After that, we'll...
Recently, I read an article by a nephrologist in India. It says that regarding the salt substitutes which are being marketed, not everything has sufficient quantity of the potassium. That's 20 or 25%. There's a wide variability in that, and that needs standardization if the salt substitute has to actually work. Can you please enlighten me?
So as I said, salt substitutes that are available in the country are only 4 or 5 brands. And I don't want to name, but they are leading brands like Tata's and ITC, etc. So, and they claim a salt content of 20 to potassium content of 20 to 40%. So the regular brands are okay. But if you are going to buy some salt substitutes in a smaller places which are not branded, I'm sure you have to be careful on the potassium content, which could be variable.
I think it was a wonderful talk given by Dr. Rajan, as well as a wonderful discussion by the participants. All the audience also, they had a very good participation. Thank you very much, Dr. Rajan. Just give
Thank
a
you.
big hand.
I think after listening to Dr. Rajan Ravichandran and the expert comments by Dr. Shashank Joshi, many of you, I presume that you will not take salty food this night. Totally avoid poppers, appalams, and then pickles and all those stuffs. And I'm sure you will not add salt to your soup also. Okay, having listened to this excellent lecture, thank you very much, moderators. The other terminology that has been used here is the salt satyagraha. That reminds me about our father of nation, Dr. Mahatma Gandhi's yatra. So let us now listen to Shishish, the senior vice president of Microlabs, to talk about this project, what they have started 1 year ago. Please.
First of all, thank you, Dr. Rajesh Ravichandran, for a wonderful deliberation on salt. I think this has set a stage for us to take this initiative forward. Good evening, everybody. And on behalf of Microlabs, a very heartfelt thanks to the office bearers of Indian Society of Hypertension and World Hypertension League to have gracefully accepted and allowed us to host this evening's pre-conference satellite symposium. This symposia is being live streamed across 33 centers across the country, and it is being watched live by close to 2,000 doctors and probably a few more hundred on YouTube Live. I think this program is reaching close to 2,000 plus people. And probably this is the first time in India, the global and the Indian luminaries on hypertension are sitting on one single platform. And we are truly humbled to be hosting this program for us. So thank you very much for this great opportunity, and it's a privilege to host this program. Just a few words about Microlabs before I speak about the initiative, what we are going through. I think Microlabs was established in 1973, and we have just completed 50 years of our inception. And thanks to each and every one of you for being part of our growth, and we are truly humbled to be standing in front of you with this milestone of 50 years. Microlabs has been one of the giants of the Indian pharmaceutical industry and has been consistently part of all the scientific initiatives, and we would be proud and willing to continue our support towards these initiatives. And one of the recent initiatives that we have started off is the publication of the cardiology books, which has seen the light of 4 years, and we would looking at the kind of response what we have got for these books, which is reaching close to 20,000 physicians across the country. Right. Now, in 2024, that is the last financial year, we made a small but a very impactful initiative in the management of hypertension. But we always had a feeling that sugar was more luckier than salt, because sugar got all the attention and somehow salt was not lucky enough. But incidentally, we also saw the World Health Organization coming out with a global mission to reduce the salt consumption to 5 grams per day per person by 2030. And as a responsible organization, we thought this would be a wonderful place for us to start off an initiative of taking the education to the general public. I think this is one initiative one topic which would really need a lot of collaboration between the medical fraternity and the industry, because this has to reach the maximum amount of public. So this was an initiative from us, and we call it as Salt Satyagraha. we thought the Indian public was consuming more than 2 times, but like Dr. Shashank Joshi was talking, I think it's 5 times more than what the guidelines talk about. So I am on Salt Satyagraha was the initiative which we launched a year back, which was basically a social awareness initiative with a mission to achieve WHO's target of reducing dietary salt consumption by 2030 in order to prevent and control hypertension and related cardiovascular complications. And this was India's largest awareness initiative on excessive salt reduction taken up for the first time, like I said, with the objective of bringing in huge awareness in general public to reduce the dietary salt by more than 30 to 50%. And this project was initiated in 2 phases. The first phase, which was the last year, basically started off with mass awareness programs across the doctor community. We enrolled close to 15,000 doctors in this initiative. It all started off with in-clinic bringing awareness to the medical fraternity and the digital and mass media coverage which would reach the general public. And we also had a strategic alliance with the IPEN, Indian Association for Parental and Enteral Nutrition. And we also signed up a petition, which we signed up very recently. And going forward in the phase 2 for this financial year, it would be probably test India's first salt calculator with the help of clinicians. I think this is just a thought as of now, because we have no tool as on date to prove that somebody is consuming high dietary salt, because unless you prove it to a patient, he would not agree that he's consuming higher amount of salt. And we are also trying to see whether we can come up with India's first and the largest study on salt consumption patterns across various geographies of the country. Talking about the salt petition, what we said, we have signed up a petition with about 30,000 doctors across the country, basically to bring in a label on all packaged food about the salt concentration that it contains, so that the awareness at the patient level before he picks up pre-packed food would really bring in something. So again, like I said, the strategic alliance with IPEN India, we have onboarded the IPEN so that for endorsing our initiatives. And also we have a strategic alliance with Healthy5, who have actually helped us to take this initiative to reach 20 lakh people in the last 6 months' time. So I think the reach has been quite good from our end. So we'll try to see how do we take this forward. Also, this initiative of Salt Satyagraha had the first marking on global presence when this was presented at ISH, which was held recently in Colombia. So again, a global mark about the initiative has just happened, giving us a good platform to take this initiative forward. Even though it's a small start, we have been recognized and noticed across a lot of platforms for enrolling maximum number of doctors for this initiative. We were awarded the Asia Book of Records and India Book of Records. And we were also noticed as the best patient education program by the Economic Times and also the TV18. I think what we personally feel is that we have just started off a small initiative, which with every passing day, we also feel that it is a fantastic platform to be in and a huge amount of work still to be done. So I think every person who was making a comment here has given us the confidence that what we have made the right start, and we need to probably associate with more and more number of clinicians like you so that we come in with some meaningful end to this menace. So wholeheartedly requesting all of you to join us in this initiative. Microlabs Cardiology has taken the lead way to ensure this in the Indian public. I think, like I said, it would not be possible unless the public and the industry, the medical fraternity and the industry does not partner together. As Microlabs, as the industry leader, we are ready to partner and take this initiative forward. And we would approach a good number of senior consultants like you to help us out in designing a way forward for this initiative. Thank you very much. And it's really humbling and really a pleasure for us to be standing in front of you and discussing about our initiative. Thank you very much. Before we, this is for the satellite centers. If you have any questions to be put up to the panelists after the talks, there are laptops kept in every center. You can go to that center and type in your questions. That we will pick up the questions from here and try to address as many as possible. Thank you very much.
Well, thank you very much, Dr. Samak, and let me again acknowledge that Microlabs has done something that's really quite remarkable in going beyond the medications it makes and really taking responsibility for public health issues. And I only wish others in the industry would follow your wonderful example. Well, we are ready to come to heart failure. And I'm delighted to introduce three very distinguished moderators, Dr. Prabhakar, Dr. Chandrasekhar, and Dr. Kannan. And I look forward to a very lively discussion. And who's going to introduce Dr. Baum?
So I think it's always a pleasure to introduce to Professor Michael Baum. I think he's no stranger to Chennai. He gave his last talk on heart rate and heart failure in Chennai. I chaired a session, and he's such a good speaker and is proponent of heart failure in so many meetings. I think without wasting much time, let us go ahead with Professor Baum, who's one of the authorities internationally on heart failure.
So thank you very much. It's a great pleasure to be here, and I would like to thank you all for having invited me again. And we are switching a little bit of the gears. I will talk about hypertension and heart failure. And there are two things I would like to make: hypertension and heart failure. First, it is too high, and later it is too low. So that is the issue with blood pressure in hypertension. Excuse me. I think I need some help. So I would like to make the following topics. The first is heart failure and blood pressure. That's what you all know, the association to high heart failure when the blood pressure is high. What phenotypes of hypertension and what phenotypes of heart failure are induced by elevated blood pressure? Which blood pressures are important? I will come a little bit to pathophysiology. And then, of course, we have the prevention of heart failure by reducing blood pressure. And then we have something which was called decapitated hypertension by Franz Messerli. That is the fact that with blood pressure, it goes down when there are heart failure events with every decompensation. Maybe that has something to do with the Bauer effects or even with a reduction of cardiac output. But along the way towards progressive heart failure and severe heart failure, there is a drop in blood pressure. And that is indeed a very important thing. That's a treatment barrier to implement guideline-directed medications in heart failure patients. Now, what is heart failure and high blood pressure? I do not want to go deeply into this. You see patients, this is very old data from the Framingham study. You can see patients who have an elevated blood pressure develop heart failure, normotensive, mild, and definite hypertension here. You can see that this is strongly age-dependent, so this is an age-associated syndrome, so to speak. And of course, it is not much of a difference between men and women, because in that time, of course, heart failure more or less was defined as heart failure with reduced ejection fraction. But now, and I will come later to this, we know much more because females more prevalently have heart failure with preserved ejection fraction. So you know all this. This is a 1.5 million people study, and you can see that all cardiovascular outcomes are increased age-dependently, again in hypertension, and among them there is of course heart failure. A normal blood pressure has this curve. There is indeed heart failure, new onset of heart failure, but you can see in elevated hypertension there is a left shift of these time event curve by approximately, depending on the age, of 5 to 8 years. So heart failure is closely associated with heart failure, blood pressure, but this is not the only case, because there is of course an asymptomatic left ventricular dysfunction a huge burden of people in the population. According to the Rotterdam Heart Study, it's about 4% of the overall population, and these are old data, people who have indeed left ventricular dysfunction, and that paves the way into the syndrome of heart failure. But it's not only high blood pressure, because there is a lot of comorbidities. Here is the hypertension story, but there is obesity, there is metabolic disease, and of course there is kidney disease. And then of course, when blood pressure is elevated for a longer period of time, there are all these conditions coming together, and this forms the risk scenario for developing heart failure. And in females, aging individuals, and in patients who have atrial fibrillation, the pre-test likelihood in heart failure patients that this is heart failure with preserved ejection fraction is quite high. So what phenotypes do we have? So this is the common view about the cardiovascular continuum. Of course, when there is vascular disease and myocardial infarction, there is a loss of myocardial mass. There is an activation of maladaptive systems such as the renin-angiotensin converting enzymes expression in the heart itself, and this leads to remodeling, and this is eccentric hypertrophy, as it was classically called. But there is, of course, a shortcut which is primarily dominated by elevated blood pressure, and that is then concentric hypertrophy, stiffening of the ventricle, and in the presence of a normal ejection fraction, this is heart failure with preserved ejection fraction, now called HFpEF. Now, what are the mechanisms? So first of all, there is left ventricular stiffness, increasing the filling pressures because filling is impaired. Afterwards, there is also alongside with this, there is a dilatation of the atria, which is called atrial cardiomyopathy, causing electrical remodeling, interstitial remodeling, and also, of course, a contractile deficit of the atria, leading, according to the Laplace law, to a progressive dilatation, and then re-entry mechanisms, again leading to atrial fibrillation, reducing the capability of the atria to fill the ventricle. And this, of course, augments the syndrome. And about in the clinical trials in HFpEF, almost 50%, 30 to 50% of the patients already have atrial fibrillation. The other things is, of course, there is myocardial fibrosis in the hearts, and there is coronary artery changes in particular. There is small vessel disease, and of course, there's the different aortic ventricular coupling, and that, of course, increases the afterload of the heart, propagating cardiac remodeling. And what you can see that when you look at here the left ventricular mass index and the association to outcomes, you can see the higher the left ventricular mass is the hypertrophy progress, the poorer is the outcome, and these are indeed morbid and morbidity and mortality events which are associated to this type of cardiac, of these phenotypes. The other thing is that, of course, there is microvascular disease, in particular in the heart. There are many data on that. There is fibrosis and changes of the small vessels. And this, of course, also associates closely, this is not new data, this is quite a classical one, with poorer outcomes. You can see event-free survival here with changes of the microvasculature, and then you have an elevated number of cardiovascular outcomes. Now, which blood pressure parameters are important to induce heart failure? It is very likely that aging has an impact, as heart failure is very strongly associated, very closely associated with age. And what you can see, of course, at different levels here of blood pressure, of course, there is indeed a pulse pressure which is increasing, and this is indeed increasing the risk. Now, when you deeper look into these phenotypes, you can see diastolic blood pressure is indeed dropping over time. But when systolic blood pressure in the aging population goes up in isolated systolic hypertension, then there is an association to outcomes. And of course, when pulse pressure is increased, then there is an excessive increase in the incidence of cardiovascular death here, but also of heart failure incidence. Now, why is it so? That is stiffening of the arteries. And this is from Paul Sobotka, who indeed looked here in this model to show a very stiff tube, and you can see a sharp increase here in the blood pressure. But when there is something which is something like the Windkessel function of the aorta is mimicked in this experiment, you can see the blood pressure, the pressure in this tube is not as high as in this condition. And this is something which shows clearly that the stiffening, which is age-related, increasing, of course, systolic blood pressure, increasing pulse pressure is closely associated to these outcomes. And why is that so important? The reason is that the pulse valve is propagated rather fast, and it is reflected in the periphery, and you can see here these increase of central blood pressure. And indeed, you can see that when there is a slow transform pressure wave, it is much different to a fast transmitted pressure waves, because when the artery is stiff and there is a reflection which is very fast, it directly falls into the systole, producing an afterload increase in the heart. And this is a strong predictor of these remodeling processes by increasing the oxygen consumption of the heart, the strain of the left ventricle, and also producing vascular effects. And accordingly, and in agreement with this, you can see that there is this strong association. I took the old data from the Framingham study, showing indeed that when the pulse pressure is increased, you have an approximately 4 to 5 times higher incidence of chronic heart failure. So that is the mechanism of blood pressure and heart failure. Now, how can it prevent it? So there are several data, and this is from Dr. Tomopoulos, who indeed had huge databases on treatment effects in patients with heart failure. And what you can see is, according to all these cardiovascular complications, the strongest effect and risk reduction is happening with heart failure, which is the broken red line here, the risk reduction when blood pressure is controlled, and it is similar strongly reduced when concerning stroke reduction. Now, of course, this is shown in many studies that heart failure can be reduced, but this is here the Harvard study, I think with the clearest result in elderly people over 80, and blood pressure reduction shows here this huge reduction of heart failure outcomes, heart failure hospitalization, which is very important, of course, among a reduction of the other cardiovascular endpoints as well. Now, what should be used? All head studies and others have shown that, of course, diuretics have a strong reduction of heart failure incidence. It might be that they only postpone the first decompensation and overloading of the body with fluid, but at least these people also die earlier. There was a lot of discussions about that, and you can see what is expectedly in hypertensives. ACE inhibitors produce a significant blood pressure reduction, while there is a slight increase with calcium blockers. However, these could just be edema formation, but together after the implementation of ACE inhibitors, this effect was gone. So these are the data of these meta-analyses. Now, what happens when heart failure is occurring? Decapitated hypertension and low blood pressure is a real problem. So this is a recent analysis here from Switzerland, and you can see that patients who have a rather sharp slope over time of a blood pressure reduction, slope here minus 10 millimeters of mercury over time per year, you have a 50% increase in heart failure morbidity and mortality. That means cardiovascular death and heart failure hospitalization, which is the most common endpoint in heart failure studies. And what you can also see, when the blood pressure, the systolic blood pressure is low in established disease in heart failure, there is a sharp increase in heart failure related outcomes. So a low blood pressure when the patient is entering your door is indeed a predictor of poor heart failure outcomes in heart failure patients. So we looked here in the on-target trial, and Professor Weber was always all the time on board on that. And you can see that in this population, which has 75% of hypertensives and patients with secondary prevention, Some of them had had an event like a myocardial infarction, a stroke, or diabetes plus peripheral artery disease and 2 risk factors. And what you can see that this is a U-shaped curve, not with blood pressure at baseline. This is heart failure hospitalization. This is all-cause death. But the average in trial on treatment blood pressure has an association at low blood pressure levels to heart failure hospitalization. And this is here derived from an analysis from a South Korean, this is an editorial to a South Korean registry on heart failure. And surprisingly, the nadir of the risk for heart failure is relatively high. It's 132 over 74 millimeters of mercury. These are the patients who just descriptively have the lowest risk. However, the question, what is it? Is it something like inverse causation? People who have a low blood pressure do not die from low blood pressure, they die with low blood pressure because they have more frailty, a higher comorbidity load, and more advanced heart failure. This is very likely. And the other shift here, the high blood pressure curve in heart failure is rather flat. So high blood pressure is not really a problem in heart failure in these patients. But could it be that there is some causal effect? And we looked at that in the Ephesus trial. Patients who have a high filling pressure and a low blood pressure, they have a reduction in effective coronary perfusion pressure, which of course is the average blood pressure minus the filling pressure, and you need 50 millimeters of mercury. And this might change when there are persistent coronary artery stenosis. So the Ephesus trial looked in patients who had heart failure and a coronary event, and approximately 50% of the patients were revascularized and 50% were not. And what you can see in those patients who were not reperfused, this is not PTCA, this was also thrombolysis. You can see this association of diastolic blood pressure. The lower the diastolic blood pressure, the higher is the event rate. When you then look in approximately the same number of patients, after all adjustments who are possible, you can see that this effect is more or less gone. Here with the cubic splines, there is this increase in outcomes in patients after MI with heart failure at low diastolic blood pressure, and this is flattened after reperfusion, indicating that there can be something behind it, but of course it does not exclude inverse causation. This is an open debate which is discussed back and forth. Now, why is it a treatment barrier? And why is it so bad to have a low blood pressure? So this is here one of the blood pressure analysis we have done now and available almost for every heart failure trial, a blood pressure analysis. So there is a reduction of left ventricular systolic function, cardiac output drops, and blood pressure goes low. And then, of course, people are less treated with guideline-directed medications, either because they do not tolerate it, but the main problem, in my personal view, is that physicians are reluctant to use them because they are afraid of hypotensive side effects. So that is a problem here, and that altogether, of course, leads to an increased hospitalization. When you really look into the data, it looks a little bit different. So we looked here in the paradigm study, and we did it also in the SGLT2 inhibitor trials. It's always the same. Whether the treatment effect is changed, separated the population in patients with a blood pressure at baseline below 110, 120, 130, 140 and above. And what you can see that the treatment effect is maintained. There is no heterogeneity between the effect to reduce risk of sacubitril valsartan in patients with heart failure and reduced ejection fraction. A typical clinical scenario is that the patient, after initiation of therapy, either with enalapril, which was the active control group in this trial, or sacubitril valsartan, drops with the blood pressure below 100. So these are the population below 100, and this is above 100. And there are 3 messages. First of all, what you can see, what has been said before, that patients who have a low blood pressure have a higher outcome rate. From left to right, you can see it. And then, of course, you can see that there is a treatment effect, which is always approximately 20%, which is relatively the same. But absolutely those patients where it gets tricky, where the blood pressure is low and where is indeed the possibility of occurring of side effects, they have the higher absolute risk reduction compared to the low risk population. So if the blood pressure is low and there are drugs which work, then try to get them on board, because in absolute terms, you gain more than you lose. Now, what about SGLT2 inhibitors? The effects are tiny, so they eliminate some sodium, and so cardiologists think, oh, what happens to blood pressure if it's low? What you can see that indeed, the lower the blood pressure, the less is the blood pressure drop on SGLT2 inhibitors. There is none effect with empagliflozin in the Emperor Reduced trial, and when the blood pressure is about 130 to 140, there is 2 to 4 millimeters of mercury drop, which is not very much. And what you can see that the event rate, the lower the blood pressure is higher, it's shown here. But on every step of systolic blood pressure at baseline, there is a positive treatment effect. And with a linear regression, you can see that the line of neutrality on the right-hand side is indeed here never hit. So there is a homogeneity of the treatment effect across the whole blood pressure performance. And that, of course, holds also true for the kidney. Excuse me. You know that there is a protection of eGFR slope, so the decline is attenuated by SGLT2, and that is also independent of blood pressure. So the pressure diuresis to have these potential effects apparently is not important. So these effects are maintained, and this has been also shown for dapagliflozin. It has also been shown for the HFpEF trials, DELIVER and Emperor Preserves. So we have looked at all of this. So taken together, heart failure is associated with elevated blood pressure. More or less, when blood pressure dominates the phenotype of heart failure, it is associated with heart failure and preserved ejection fraction in concert with being a female, being overweight, having diabetes. And predictive is the detection of atrial fibrillation, increasing the pretest likelihood. You can see prevention of heart failure should be done by consequent blood pressure control, in particular in the elderly people. And when blood pressure is established as a syndrome, then there is decapitated hypertension with an increase of hospitalization and death rate the lower the blood pressure is. But this should not be a barrier to implement treatments, because all what we have seen and known is that all the agents work similar in the relative treatment effect, but even more pronounced in the absolute numbers of patients saved. So the number needed to treat gets smaller. Thank you very much for your attention.
Thank you, Dr. Michael Baum. It's indeed an excellent talk. You nicely alluded to the importance of treating these patients with heart failure with hypertension. And, as you said rightly, so I have a query to ask to you. What would be the role of exercise training in patients with hypertensive heart failure?
You name it correctly, hypertensive heart failure. We called it recently hypertensive heart disease. And this implies and has a connotation. It is the only thing we can do is adjusting blood pressure. Now we have specific treatment, so it's heart failure with preserved ejection fraction. Exercise training, there are now 5 studies. The most recent one just is published in Nature Medicine, showing that exercise performance is increased, which is nice because these patients have a high load of dyspnea and high rates of overhydration. There is now no evidence that it reduces outcomes, right? That is the problem. Unlike in the heart failure with reduced ejection fraction, there is this ACTION trial, which was a program screening thousands of patients, ending up with 150 in every group, showing that there is a benefit. But with preserved ejection fraction, it should be done because it increases fitness, reduces symptoms, improves quality of life, according to the KCCQ questionnaire, but there is no evidence for endpoint reduction so far.
Yeah, particularly in the developing countries, like we do have another issue is like the BMI. So the increase in the BMI and the other comorbidities. What would be the influence of other comorbidities, particularly the anemia, sleep apnea, and worsening renal function?
That is true. So there is The point is for the heart failure population in general, there is a reduction of the cardiac death rates. This is pump failure and sudden death, but non-cardiovascular death is steadily increasing. And nowadays, in reduced and preserved ejection fraction, more people are dying from non-cardiovascular causes rather than from typical cardiac death. With HFpEF, the problem is that the comorbidity load is higher because these are elderly people in the trial. So you select people who have a higher comorbidity load. And of course, also the non-cardiovascular death rate is higher. The cardiovascular death rate is lower, and the all-cause death is approximately the same. So that is the difference, right?
Well said, sir.
Sir, there are two questions in the chat box. I don't think it's for Professor Baum. But first of all, I should congratulate Professor Baum on taking hypertension to hypotension and heart failure. And there's a term which we commonly use in when we give a talk and tell them, look at symptomatic hypotension and not hypotension when you start treating. Your comment on that?
That is a good point. There is just a paper we published on the Paradigm study and Paragon study, putting both together. There is an effect of asymptomatic hypertension, and the outcome effect in symptomatic hypertension is even more. So this was evaluated. So symptomatic hypertension is more prominent. What you see in the trial is usually symptomatic hypertension. So that is a reason to withdraw therapy. Just a low number of blood pressure should not be reacted to by reducing guideline-directed medication when the patient is feeling well. That is a very important point.
Thank you, sir. There are two questions in the chat box that has come from the other centers. One from Kochi, probably I will have to take it, sir. Can the usage of potassium chloride cause hyperkalemia? I don't think it's for you.
Potassium chloride can cause hyperkalemia.
Yeah.
Yes.
I think it's. I don't know. This
yeah, sure, it
question
can.
from
In
Kochi,
particular,
the way he
we
asked me
have
this question.
approximately a 50% prevalence of impaired kidney function in heart failure. Again, it's about 20% higher in reduced, in preserved and reduced ejection fraction. So, of course, hyperkalemia is a problem, in particular when MRAs are used in the heart failure treatment.
There's another question from Raipur. I don't think it's from you. It says, what is recommended salt sodium per day dose in different grades of chronic leishary disease? From Professor Smith Srivatsa.
That is another interesting question. So there is always the recommendation, which was in the guideline 2012, you should have a water and salt restriction. Yeah, it can be 1 gram, which is very low. Nobody could do it. And also water restriction. Meanwhile, there are observational studies and also randomized controls from Sweden, and none showed indeed a beneficial effect by salt and water restriction in heart failure. When there is a decompensation, of course, then it's a matter of getting rid of the salt. There is definitely excess salt, and then the water is mobilized accordingly. And therefore, spot urine sodium is recommended in the acute heart failure setting.
Dr. Parandaman wanted to ask something. So in Chennai, we have a rule that if Dr. Parandaman doesn't ask a question, the meeting is incomplete. He's very popular here with his questions.
Wonderful presentation. With the reference to the acute heart failure, what is the role of serum sodium, which will help to predict the mortality in acute setup of heart failure?
Yes.
Serum sodium.
Hyponatremia is a real driver of poor outcomes. This is dilution hyponatremia. This reflects an overload in water. And this has been studied in India the first time by Roberto Ferrari and Ander Inand many years back in non-treated heart failure patients. So if the patient is volume overloaded and has hyponatremia, then in my view, he belongs into the hospital. Of course, MRAs should be withdrawn. Thiazides usually do not work anymore. And this is loop diuretics and neuroendocrine antagonists under hospitalization when there is indeed severe hyponatremia. That is a sign of a poor outcome, high rehospitalization rate and high death rate. Yeah. Of course, when you overtreat the patients over many times and he's dry, very dry with diuretics, and there can be a deficient sodium content, but this is usually not not low. But even though there is hypovolemia and hyponatremia, that is predictive for a blood pressure drop after ACE inhibitors or sacubitril/valsartan. This has been shown many years ago.
Thank you, Miss.
Well, any, go ahead.
Sorry for interrupting, sir. Why I got up because hyponatremia and heart failure was my thesis topic. It was my thesis topic where we selected in my GH, we selected 250 people and we observed that even the sodium level of 132 was also having the detrimental effect on the hyponatremia with the heart failure. It was my thesis topic where the Goldberg meta-analysis and all the things was done and the patient we found out and even the we presented in the topic also, and the cause was found out to be that sodium has a multi-diverse effect where we had, and in your practice and
Yeah, it is delusional hyponatremia. The worst thing you can do is substitute sodium, right?
Thank you, sir, for it. My question is that in a patient of isolated systole,
Yeah, there is a trial called CAFE trial showing that the central blood pressure is increased with beta blockers from Brian Williams. Whether this has an outcome effect is not clear. You see all the discussions with beta blockers in hypertension. I would not like to go very deep into that, but of course, high heart rate is associated to poor outcomes. Also in hypertension, in coronary artery disease, and in heart failure, but it has never been shown that heart rate reduction improves outcomes. Once there is heart failure with systolic dysfunction, so HFrEF, then of course heart rate should be between 50 and 60 because the risk sharply increases at a heart rate in sinus rhythm, not in AFib, above 70. So then the beta blocker is clearly indicated, but the criterion is systolic function and it's not the height of the blood pressure.
Well, thank you very much, Professor Baum, and of course we'll be hearing more from you during the World Hypertension Congress over the next 2 or 3 days, and we're very much looking forward to that. I do want to thank, first of all, our sponsor for this program, Microlabs. I think our ability to speak to colleagues all over India is really quite remarkable, and I hope that they have enjoyed it as much as we have here in Chennai. I also want to thank 3 people in my close vicinity here, Dr. Narasimhan, Dr. Prabhakar, Dr. Chandrasekhar. These 3 gentlemen have, on behalf of the Indian Society of Hypertension, put in an enormous and brilliant effort in helping to create the World Hypertension Congress. And for those of us who are affiliated with the World Hypertension League, are very appreciative of the opportunity to work with these very distinguished colleagues. And we're looking forward very much, and I know I speak on behalf of Professor Paul Welton, the president of the World Hypertension League. We're all looking forward very much to the next 3 days of science, medicine, and collegiality. I hope we'll see you all at the sessions beginning tomorrow morning at 8 o'clock. Thank you all very much for being here, and we'll see you later.